acknowledge I'm a breast cancer doc, so I won't say too much about the science of today. The goal really was to have a conference that was community provider facing. I can tell you we have a fair number of folks who will be in the room, but we'll also have a fair number of folks watching virtually. And then hopefully more people will filter in as we get moving. Just a little bit of background of UICC. I think everybody's familiar with the large cancer centers in the city. We're one of the largest as well. We actually are the largest academic public university with a cancer center like this. We're a matrix cancer center. And I moved here in 2020 to help the process of NCI designation at our cancer center, a process that we're well on our way. Part of that is, of course, making sure we do excellent community-based education of not just trainees, but practicing providers. So that's really the genesis of this particular meeting. Today, I'm going to introduce Ryan Nguyen, who's going to be the chair of this particular session. And I would ask you direct questions towards him. Ryan is he's a thoracic oncologist with an interest in lung cancer specifically. He joined our faculty 2 years ago.
2 years.
And has just honestly hit the ground running, and no one here is allowed to steal him.
Thanks, VK. I hand this back to you. Okay, awesome. Thank you so much, everyone, for joining. Thank you, Dr. Gotti, for the introduction as well. Like you said, my name is Dr. Ryan Nguyen. I'm an assistant professor here at the University of Illinois Cancer Center. I want to welcome everyone for being part of our first inaugural CME event. I know we've got events lined up the next 2 Wednesdays as well, so we're very excited to have everyone be part of this great opportunity to learn about all the exciting new updates that we have in the field of cancer research. We can go to the next slide. Just a few housekeeping things to start off with. Here's the Wi-Fi in case you need that. Go ahead, take a picture, but we'll have that out in the lobby in case you need that as well. Please do sign. If you haven't already, please scan the QR code so you can sign in. Yeah, I think we're good. Yeah. And then for anyone who is obtaining CME credit, we do request that you complete the pre-test. So feel free to I'll give everyone a second to scan this. We're going to have this QR code up a couple of times throughout the day. So if you do miss it, we'll have it up again. But you will have to do a pre and a post test in order to get the credit for today's session. We'll give it a second. Okay, I think we're all good. All right. Here's today's agenda. So today we'll be talking about GU, GI, and thoracic oncology. We got some really fantastic and wonderful faculty who are all part of the UI Cancer Center. And we're going to be starting off with Dr. Karine Tawaji, and then who will be covering GU. Dr. Shika Jain will be covering GI updates, and then Dr. Frank Weinberg and myself in the later parts of the evening will be covering thoracic oncology updates as well. I do want to thank all of our sponsors and exhibitors who made this program possible. So especially thank you to everybody who came out here to sponsor and are a vital part of the cancer research community. And with that, we're going to start with Dr. Karine Tawaji. As you can see, Dr. Tawaji is not physically here, but it's because she has such a commitment to cancer research that she's actually at the ASCO GU symposium that's in San Francisco right now. They wouldn't move that conference for ours, so we decided to let her record it virtually. So she'll be actually giving a virtual lecture today. So I will be giving her introduction, and then at the end of her lecture, she'll be open for questions. She will be joining us virtually at the end. So Dr. Karine Tawaji, she's an assistant professor of medicine in the Department of Medicine at UIC. She is triple board certified in internal medicine, hematology, oncology. She is also the acting program director of our fellowship program, and so she's very involved in the medical education of our fellows. She also co-hosts the 2 Onc Docs podcast, which is a podcast which gives all the new updates for in oncology and cancer research, and something I actually listened to when I was studying for my board exams as well. She's very active on social media and kind of promoting kind of the newest updates in cancer research as well. This is Dr. Tawaji's disclosure side. She has nothing to disclose. And with that, I'm going to turn my mic off and we'll go ahead and let her lecture start. Thank you.
Check. Can I hear that? Hello, hello. For the video or just for you? You know, if I said anything.
We can try one more time.
And we'll should we just restart it? Right.
Okay, he said he could hear the chat, so I think
Okay.
we can try it one more time and then we'll.
Right-sided hydronephrosis secondary to mass effect from the lymph nodes as well as osseous involvement. A biopsy, surprisingly, of the left cervical lymph node was consistent with prostate adenocarcinoma. And at the initial oncology visit, the PSA was over 1,500. And so the patient was ultimately diagnosed with de novo high volume metastatic prostate cancer. And we recommended triplet therapy with the chemotherapy docetaxel as well as abiraterone prednisone and androgen deprivation therapy or ADT, which we normally use leuprolide based on the PEACE-1 trial. And so there has been a changing landscape for metastatic castrate-sensitive prostate cancer. And so these are the NCCN guidelines as of 2024. And so you can see that for patients with castrate-sensitive prostate cancer, now there is a role of triplet therapy with androgen deprivation therapy, with docetaxel chemotherapy given for 6 cycles once every 3 weeks, in addition to abiraterone, which is a second-generation anti-androgen based on the PEACE-1 trial, or darolutamide based on the AirSense trial. I also wanted to note that it's important to consider for patients with oligometastatic prostate cancer to be considered for definitive treatment in the form of radiation to those sites if there are limited sites of metastases. So what is the criteria for this triplet therapy? So the benefit has most convincingly been shown in males with high risk and high volume metastatic disease. And we had updates on this at some of the ASCO conferences in 2023. And those criteria include patients with visceral metastases and at least 1 bone lesion, or at least 4 bone lesions with at least 1 outside of the axial skeleton, or if they have Gleason score 8, or if they have de novo metastatic disease. And the patients need to be fit for chemotherapy based on their performance status and agreeable to a port placement if the institution requires that. And then what about the role of local treatment in metastatic disease? So we know that often in stage 4 cancers, we don't offer definitive treatment to the primary, but there is a role in some cancers, including in prostate cancer in men with a low burden of bone metastases. And that is 4 or fewer bone metastases with none outside of the vertebral body or pelvis and no visceral metastases. And this is based on the STAMPEDE subgroup that showed an improved overall survival in patients with a low metastatic burden. The same benefit was not seen in the PEACE-1 trial. However, there is another trial, the SWOG 1802 trial, which we also have open here at UIC, which will further help answer this question. And this is randomizing patients to standard systemic therapy plus definitive treatment with patient preference of surgery or radiation to the primary tumor. So I've shown you how the field of castrate-sensitive prostate cancer has evolved in the last few years, but it will likely continue to change. So 2 phase 3 trials that I wanted to highlight here are TALOPRO-3 and Amplitude, which are evaluating the role of PARP inhibitors, which I'll talk about later, in that earlier setting. There's also PSMA addition, which is looking at lutetium PSMA, which I'll also talk about later in the earlier setting. And we'll briefly, in a little bit, talk about where it is approved right now. And we know that there is this evolving field of precision medicine in prostate cancer. So we know that precision medicine exists in a lot of other cancers, like lung cancer, for example. But really, I think the time is now for precision medicine and prostate cancer. And you can see some highlights of trials looking at kind of modifying the therapy based on certain features of the patient's prostate cancer. So then, now that we have this more intensified therapy in the castrate-sensitive prostate cancer setting, what comes next after resistance develops? And so this is showing us some of the changing landscape for castrate-resistant prostate cancer. So these are all of the approvals, and then I added a few others that were approved last year. And so in 2020, we had 2 monotherapy PARP inhibitors approved, rucaparib and olaparib. And then in 2023, we had 3 combination regimens, olaparib, abiraterone, talazoparib, and enzalutamide, as well as niraparib, abiraterone. So to highlight our discussion, let's move on with our case. We have our 65-year-old gentleman who received that triplet therapy upfront and now is found to have a rising PSA on routine follow-up. At this time, the patient is asymptomatic. A PSMA PET is ordered and reveals new adrenal and liver metastatic lesions with an SUV max of 12, consistent with metastatic castrate-resistant prostate cancer. So germline testing is sent and the patient is found to have a BRCA2 alteration. We normally, I just want to note, would also do somatic testing in this setting. So what treatment would you offer next? So some of the options that could be considered because the patient has a BRCA2 mutations are single agent PARP inhibitors or in combination or further chemotherapy or lutetium-directed radioligand therapy. So let's talk briefly about the homologous recombination repair pathway. This repairs double-strand DNA breaks, and we know that patients that are deficient in this accumulate damage. And these are very prevalent in prostate cancer. So about 6% of patients with localized disease have germline mutations, about 12% with metastatic disease have germline mutations, and about 20% have somatic mutations in advanced disease. And this figure is showing us presumed pathogenic germline mutations. And you can see that BRCA2 is the most frequently found at 44%, followed by ATM, CHEK2, and BRCA1. It's also important to note that patients with BRCA1 and 2 mutations tend to have worse outcomes. And so you can see based on this bar graph, with the gray bar being the overall survival, that for all patients, the overall survival based on this study presented at ASCO was 26.1 months for all comers versus 18.3 months for patients with BRCA mutations. So PARP inhibitors can prevent cells from repairing damaged DNA, and this is done by the accumulation of single-strand breaks, entrapment of the PARP DNA complex, and ultimately this results in synthetic lethality. So we know that PARP inhibitors have a defined role in patients that have deficiencies in their homologous recombination pathway. The NCCN recommends germline and somatic testing in most patients. So as you can see here, for patients with metastatic regional node positive, very high risk localized or high risk localized, germline testing is recommended for all of these patients. You can also note down here that if someone has a first degree relative with prostate cancer under the age of 60, they should also be referred for germline testing. And then somatic testing is considered for most patients in the castrate-resistant prostate cancer setting, but we're increasingly, as I showed you, that field of precision oncology is evolving, we're considering it more and more in castrate-sensitive disease. I wanted to highlight a study that our GU team presented at the ASCO Quality Improvement Conference last fall, and we have developed a pathway where we're doing paired germline and somatic tumor testing with pre and post test education by our own oncology providers. So myself and Dr. Razin, as well as our nurse practitioner. And we only are referring patients with positive germline variants to genetic counselors. And our data shows more underrepresented minority populations with greater variants of unknown significant rates compared to the current literature. And we're also finding that we have much less actionable alterations, like I showed you all of those homologous recombination repair mutations in our population, about 6% versus that reported 11% in these minority populations. And so we do have a couple approvals for PARP inhibitors, as I mentioned. So this is a table that my colleague, Dr. Razin, created, and you can see that not all of the PARP inhibitors or combinations are approved for the same biomarkers. So you can see that olaparib and talazoparib and enzalutamide is approved for all of the following homologous recombination repair mutations, whereas the others are only approved for single agent, are only approved for BRCA1 and 2. And so not all mutations respond equally to PARP inhibitors, so that's also important to know. So although the approval is broad for some of these combinations, the efficacy is not the same for all of these mutations. So you can see the blue bar is for patients that receive olaparib versus the control is the red bar. And so for patients with BRCA2 mutations, you can see that if they received the olaparib, the overall survival was 24.8 months versus 15.2 months. But then you can look at some of these other ones. For example, CHEK2 down here, actually the control did better than the patients with olaparib. So even though patients have these mutations and the approval is there, we know that the efficacy is not as good. And some of the benefit that is derived from, that is seen in these trials is derived from those patients with BRCA2 mutations. It's also important to note that these PARP inhibitors, of course, have their own toxicity. So a lot of them are similar to chemotherapy in the form of cytopenias and GI toxicity. And almost half of patients do require dose interruptions, a quarter dose reductions, and then 20% end up having these discontinued for adverse events. And then this is again just highlighting that depending on the PARP inhibitor, there are different cytopenias that are more prevalent. So for example, thrombocytopenia is more frequently seen in talazoparib than some of the other PARP inhibitors, as well as niraparib. And so there are additional treatment nuances for PARP inhibitors. So as I mentioned, which genes benefit? Not all respond equally. And then what is the role in patients that don't have these mutations? How can we maximize and synergize this efficacy? When and how to treat? So now we have these combo approvals, but a lot of patients are seeing these combo hormone therapies in earlier settings. So how does this fit in? Is there a role for more efficacy or increased synergy if we use these in earlier stages in that pre-androgen resistant state? And should we be thinking about concurrent or sequential treatment? What are mechanisms of resistance? And then is there a role for better or more selective PARP inhibitors? And so there are a lot of studies looking at other combinations of PARP inhibitor trials. Just want to highlight one of the phase 3s listed in this table, which is olaparib with pembrolizumab versus anti-androgen therapy. And this is for an unselected population. So I'm presenting the same case now, the same patient that had that triplet therapy upfront with a rising PSA now, still asymptomatic. We ordered a PSMA PET and it reveals new adrenal and liver metastatic lesions with the SUV max of 12. So he has, again, metastatic castrate-resistant prostate cancer. And now we send next generation sequencing as well as germline testing, and the patient does not have any actionable alterations. So what treatment would you offer next? So in the previous vignette where the patient had a BRCA2 mutation, I think most providers would consider a PARP inhibitor, probably as single agent since the patient already had seen abiraterone in the earlier setting. But in this setting, the patient does not have the mutations. So what do we do next? So some of the options could include switching to a different anti-androgen, although we know that for a lot of patients, the responses are poor. Docetaxel rechallenge, depending on how long it had been since the patient had completed the chemo, switching to cabazitaxel with carboplatin, lutetium PSMA, radium-223, or sipuleucel-T. And so the landscape, as I have mentioned, has changed a lot. And one of the other major approvals in castrate-resistant prostate cancer was in March 2022 when we had the approval of lutetium PSMA for patients that had received a prior anti-androgen and a prior taxane chemotherapy, such as our patient in this case. So PSMA is a cell membrane protein highly expressed on the surface of prostate cancer. So it stands for prostate-specific membrane antigen. And there are two diagnostic radiotracers. One is gallium-68 and the other is F18 piflufolastin. And we get these scans now in very high risk prostate cancer, biochemical recurrence, and metastatic castrate-resistant prostate cancer. Sometimes there are issues with insurance approvals for these scans, but increasingly it's getting a little bit easier, and we are doing a quality improvement project at UIC looking at this process. Also important to note that there are 15% of prostate cancer lesions that are PSMA negative, and a lot of those tend to be more of those small cell neuroendocrine prostate cancers. And so what is 177 loop PSMA? So it's a beta particle radiation that is taken up by PSMA positive cells and surrounding tissues. And then internalization of the radioligand results in accumulation of radioactivity in tumor tissue and irradiation. And it's given us six injections over 4 to 6 weeks. It requires a lot of coordination with nuclear medicine, and we finally have our first patient getting this therapy at UIC this month. Hydration is extremely important because of the renal toxicities, and then it also leads to salivary gland issues as well. And the approval for this is based on the VISION trial. And so this looks at patients that got lutetium PSMA compared to standard of care and that had previously received an anti-androgen or taxane regimen. It's important to note that the comparison arm did not offer the option of chemotherapy like cabazitaxel, which would be a reasonable option to consider in patients that qualified. And it did show an overall survival benefit, as you can see on the right hand here with the curve separating and a difference in median overall survival of 15.3 versus 11.3 months. And then the therapy trial was a randomized phase 2 trial that looked at patients that received lutetium PSMA post-docetaxel versus cabazitaxel. And it resulted in higher response rates, longer PFS, and reduced grade 3 and 4 toxicities compared to cabazitaxel. Another study that was just presented at ESMO this past October is the PSMA-4 study, and this is looking at the role of these radioligand therapies in the pre-chemotherapy stage. And it did meet its primary endpoint of rPFS with a difference of 12 months versus 5.6 months. But the overall survival data is still immature, and there was a high crossover rate here. So there are a lot of outstanding questions when it comes to these therapies. One is, how do we monitor the response? Is there a role for repeating these PSMA PETs? And what is the role of imaging in treatment selection? What is the optimal dose? As of right now, it's a fixed dose. As I mentioned, in the US, it's generally given up to 6 cycles, but is there a role for more adaptive dosing or adaptive strategies? How do we sequence this with other therapies? How do we manage the toxicities? And how do we prevent and overcome resistance? Because a third of patients don't respond. What is the role of other radioligands? So there are a ton of other radioligands being studied right now. So there's alpha emitters that have higher energy transfer and are more potent. And finally, we really need equitable access to these therapeutics. You know, it was definitely a huge effort to get this here, and a lot of community sites may not have access to these therapies yet. And then there are also studies looking at this in earlier settings. And so these are some of the phase 1 to 3 studies looking at this. I already mentioned the PSMA addition, which had some ESMO results. So it will be exciting to see what the results of these studies are in the years to come. Also, this is being studied in combination regimens, you know, with anti-androgens, with immunotherapy, and then with tyrosine kinase inhibitors and PARP inhibitors. So we look forward to those results as well. And so what I've highlighted to you is just a small area of how much prostate cancer therapy is evolving right now. There is a huge boom of other therapies like bispecific antibodies, T-cell activating constructs, antibody drug conjugates in prostate cancer. So really, it's a new era when it comes to prostate cancer trials and the future of prostate cancer treatment. And I just want to highlight our clinical research portfolio. So we have many trials here. This is for the non-metastatic setting. And then also in the metastatic setting, that 1802 trial that I mentioned to you for castrate-sensitive prostate cancer, which is offering patients radiation or surgery to the primary. And then we have a lot of startups for castrate-resistant prostate cancer that should be starting soon as well. I wanted to thank you, and I thank my colleague, Dr. Riesing, for her input as well, and I will now welcome any questions. Thank you.
Okay, thank you, Dr. Tawaji, for that excellent talk, and thanks for making yourself available all the way from San Francisco. I know we've got folks who are both in the audience as well as folks who are online. So I'd say for anybody who's online who has any questions, please put them in the chat. We'll go through the folks in the audience first, and then we'll get to the ones in the chat. So anyone in the audience who has a question, we'll try to get everybody a mic too. Thank you.
Hi, Dr. Tawaji. VK Gotti here. You might know me.
Hi, VK.
So you mentioned that a salivary gland toxicity with the radioligand therapies, is that related to an on-target uptake, or is that a non-specific accumulation of the radiation emitter in the salivary glands? I'm trying to understand the mechanism there.
It's an on target. There is PSMA expression in salivary glands. So I think some of the radioligands that are in development right now, there's other than PSMA, there's SEEP is another one that's being explored. There are other ones that are more specifically just expressed in prostate cancer cells. So I think we'll see more of these, maybe that will have less of these other toxicities in the years to come.
And then last follow-up question related to that, how bad is that xerostomia?
It can be quite bad. So we definitely, sometimes patients do need to have a break from their proposed regimen of the 4 to 6 cycles. Again, we don't have too much experience with it yet at UIC, but we're definitely going to have to keep an eye on that and figure out how to manage those patients if those toxicities do come up.
Any other questions? One question that oh, do you have a question? Yeah, here you go.
Hi, it's Mary Pasquinelli. Great presentation. Thank you. You were talking about the germline testing, and it was like on the second case. I just wanted to know, when is germline testing should be done? Should it be done on the initial diagnosis, or with yours, it was on the second case after the patient recurred? So I just wanted to see if it should be just done on the right away or on progression.
Usually we do it right away at initial diagnosis. So even in the high risk localized, very high risk localized, in any setting, we're sending it right away. It doesn't therapeutically impact what we do until the metastatic castrate resistant setting, but we are sending it right away.
But then yeah.
Yes, so then we know, maybe how the patient's disease will evolve as well in terms of how it showed that bar graph with worse survival outcomes with some of those mutations.
Great, thank you.
I did have one, Dr. Tawaji, this is Ryan. I had one question. With all the different options you have with triplet therapy now, how do you decide when you have a patient who has like a BRCA1 mutation, how do you, and that you think they're a candidate for triplet therapy, how do you decide between the different regimens?
So I guess by triplet, you mean the PARP inhibitor combinations in metastatic castrate-resistant prostate cancer?
Yes, yeah.
Yes. So yeah, for BRCA 1 and 2, obviously we have 3 options. For the ones that are maybe non-BRCA, we have the talazoparib combination. That actually is one pill, so that might be, there's a combination pill where it's a patient just has to take the combo of the pill, but that may also be more difficult if there is toxicity in terms of adjusting the dose. We're actually, as I showed in one of the slides, not seeing these patients at a very high frequency. I would say in general, you kind of have to think about the toxicity in the patient. And for example, if you think that they might tolerate abiraterone more, that might be a consideration to use one of the combo regimens with abiraterone. So I think that has been generally how I think about it. If a patient had a preference to just do one pill, I would do the talazoparib combination, but then I would be a little bit worried about, how to adjust the dose moving forward if there was toxicity.
Got it. Thank you. Any other questions? Okay. I don't think we have anything online. No online questions. Okay. Well, with that, we'll go ahead and wrap up. Thank you again so much, Dr. Tawaji, for giving the talk and for being available via Zoom. We appreciate it.
Thank you so much for having me.
So we do have the next session will start at 2:50. We've got about 10-15 minutes. So if you want to go ahead, grab something to drink, go to the bathroom, we'll get started with Dr. Jane's talk at 2:50. Okay, thank you. Take a mini break since we finished early. Yeah.
Hello, welcome to the UIC CME Amazing Series here at the lovely, I don't know what the place is called, 610. We have a beautiful venue. Good? Okay. Go say hi to someone. I'm going to say hi. I haven't seen you in so long. How have you been?
I just stalked you today.
I love being stalked. How are you?
Good.
Things are good? Life is good? Yeah.
You look great.
Thank you. Kids are good. 9, 6, and 6 now. I know. It's crazy. It's crazy.
I remember
When I was like huge. Yeah, she's 9. She's in 4th grade. And yeah, it just time flies. But it's been good. It's been really good. Thank you. I am. I'm really happy. You know, I kind of hopped around to a couple institutions where I found where I really wanted to be. And the UIC is where I did my residency. And I'm just so happy to be back. It's like I told them when I started, it felt like coming home. Like it's just been really
This
good.
is like that.
Yeah.
And that's where you need.
Yeah. And I've been fortunate. I mean, BK Gotti is like the best boss I've had in my entire life. And I tell him that he's just phenomenal. So it's been really good. Yeah. Everyone I say hi. All right. So good to see you. It's so funny. I was Googling because I've heard some people call it prodige and some people here call it protege, the trial.
Yeah.
And so I was like, how am I going to pronounce it? And so I heard multiple different versions. And the problem is half of these people have accents because they like are from Italy and France or Indian. I'm like, I'm gonna protege. But I was literally watching videos last night at like 2 a.m, being like, I'm gonna say prodige, the prodige trial, because that's what most American people say. But then I will throw in, but the Europeans say it protege, right? Exactly. It's so bad. It's so bad. How are you doing?
Good.
Things are good.
Yeah.
Yeah.
Good, right? Like,
Yeah.
I feel like I finally got my wind underneath.
Attending wind.
After being a year.
Yeah. I mean, you're killing it. Everything you're doing, you're killing it. So I mean, I don't think anybody would have thought you were faltering. It kind of was like a very seamless transition for you. Yeah.
Everything's going pretty well.
Yeah. That's good.
Trying to navigate that now.
Yeah. And unexpected, I think, challenges is a way to navigate it. Hi, I'm great. How are you?
All done, you're back into this
Well,
time zone?
I started service today, so I am.
Okay, all right.
We're gonna start. All right.
So grateful coming back from Tanzania.
Oh my
Like, I left
God.
my heart there.
We need to go get wine or something at some
Yeah.
point, like, and talk about it. It was just so amazing.
Okay.
Ready?
Do you want to connect your phone before you?
She plugged me in out there, actually.
Oh,
Yeah,
perfect.
so
Okay.
thank you.
I'll leave this just like right here for you.
Perfect. And is there a clicker to go forward, or how does it?
He'll do
This? Perfect. Amazing.
here.
Oh, yeah, so, okay,
Pretty much right.
stand there. Perfect. And don't walk around too much.
Yeah.
Okay. Okay. Don't go this way. Okay, I can do that. Got it. Perfect. I can handle that.
I answer you both.
All right.
Turn out for a second. I think we're good now. Okay, perfect. All right. Thanks, everyone. Welcome back. It is my pleasure to introduce our next speaker, Dr. Shikha Jain. Dr. Shikha Jain is a tenured associate professor of medicine here at the University of Illinois as well. She is the GI Oncology Integrated Practice Unit Lead, the Director of Communications and Strategies in Medicine, and also the Associate Director of Oncology Communications and Digital Innovations. She leads a number of efforts outside of the university, including the Women in Medicine Summit, as well as Impact. And I think personally, to me, my favorite title is that she's also a mentor to me. She taught me everything that I know about GI oncology. When I was a fellow at UIC, I learned quite a bit, not only about the practice of medicine, but also how to communicate with patients effectively. So it is my distinct pleasure to introduce Dr. Shikha Jain for our next talk here.
Thank you for that very kind introduction. And I will say Dr. Wynn here is probably one of, it's an honor to me that I'm considered a mentor to him because he is one of my favorite people I've ever worked with. He's phenomenal. So, well, we are going to be talking about something really exciting today, rectal cancer. And the reason it's exciting is because there have been so many transformative changes since when I was a fellow, which I will not tell you how many years ago that was, but it really was not that many years ago. And the fact that when I started my fellowship, I asked a mentor of mine, why do we not have really good guidelines for rectal cancer in the neoadjuvant and the adjuvant setting? And his response was, well, we basically extrapolate what we get from colon cancer and use that for rectal cancer. And I said, well, that seems silly. And so now I can speak to you about actual data that's related to rectal cancer and why neoadjuvant therapy has been found to be so effective. So let's kick it off. And hello to everybody who's watching virtually. Thank you for joining us. So disclosures, I am on a couple of different speakers bureaus and do some consulting for some of these companies, but that is my disclosure slide. So today, we'll talk a little bit about rectal cancer, a little bit about the history and background. I won't talk too much about that because I'm assuming you all have a bit of an understanding of the rectal cancer space. And then we'll talk about previous standard of care. We'll move into the role of total neoadjuvant therapy. We'll talk a little bit about immunotherapy, and we'll end with the topic that's on everybody's tongues these days, ctDNA. I'm also going to place a caveat, and I apologize to the conference organizers because my slides came in very late. The reason for it was ASCO GI just happened literally this past 4 days, so I'll have a little bit of data to share from there as well. So let's talk about colon cancer and rectal cancer. So colorectal cancer is the third most common diagnosed cancer worldwide, second cause of cancer-related deaths worldwide, and the fourth most recently diagnosed cancer in the US. And rectal cancer represents 31% of colorectal cancer cases. There's an estimated about 44,000 new cases of rectal cancer in the US annually. And this is incredibly important. So when we come up with treatment plans for our rectal cancer patients, clinical stage is used to direct decisions. And so the staging preoperatively, if surgery is indicated, is incredibly important because it directly translates to how we treat patients. And for all rectal cancers, we recommend a multidisciplinary review, specifically because the stage is so important in figuring out what the best treatment option is. Historically, local relapse in the pelvis occurred in about a third of patients with localized tumors at the time of diagnosis. And total mesorectal excision, which we will see abbreviated as TME, was the first step to improve local control. And it did that by reducing local relapses to less than 5% in some studies that were presented. Preoperative radiation was also incorporated into our treatment paradigms, and either short course or long course radiation have been found to be very helpful when it comes to preventing local recurrence. And in the neoadjuvant setting, radiation has been found to be very effective, especially in patients who had larger tumors. But the really interesting thing was radiation was found to decrease local recurrence, even in patients where surgical resection did not show clean margins. So when radiation was incorporated into rectal cancer treatment, it was really a transformative time in the rectal cancer treatment history. When it comes to staging, MRI and endoscopic ultrasound are both used very often to get a really good stage to, again, figure out what the treatment plan is going to be for these patients. We also know that preoperative systemic therapy, like chemotherapy, can be really good at predicting and preventing distant relapse in these patients. And what we're finding now, and this is not necessarily background, this is more forward thinking, we are finding that some studies are showing up to 25% of patients with locally advanced disease can actually be cured without ever having to go to surgery. Now, that is not something that me as a fellow could have ever wrapped my mind around. And even now, talking to some of my patients, when we talk about total neoadjuvant therapy, I get a little nervous because I'm used to thinking you do treatment and you do surgery, and that's how you cure patients. But total neoadjuvant therapy has actually completely transformed the way we even talk to patients about how we would sequence their care. So let's do a little bit of history lesson here. So back in the 1990s, there was a study from the Swedish and Dutch rectal cancer trial that showed preoperative radiation was better than doing surgery alone. So that's when we started to think, we should really be considering doing radiation in many of these patients to improve the chance of them not having local recurrence. Then in 2004, again, we found that preoperative chemoradiation improved local recurrence and it improved survival. 2006, they found there was no difference between chemoradiation short course versus long course. And then this is actually something we're going to be talking about quite a bit today. From 2020 to 2021, the first phase 3 evidence that the benefit of total neoadjuvant therapy was significant was in the Rapido trial and the Protege trial. So we'll talk a little bit about that today. In 2022, we started looking at immunotherapy for MSI high patients. And then in 2023, the Prospect trial came out looking at preoperative FOLFOX to look at the non-inferiority of it in the preoperative setting. I'm gonna give you a little anecdote real quick personally about me. So when I was a trainee, I really wanted to be a thoracic oncologist, and I'll tell you why. Because the thoracic oncologist got all the fun immunotherapy trials, and my third year of fellowship, I gave a talk about why ASCO was all a Twitter about anti-PD-L1 therapy. So now I can say, as a GI oncologist, there are opportunities for immunotherapy for our patients. I am very happy to be a GI oncologist, but I will say I used to get jealous of my thoracic colleagues. So now I can brag about our immunotherapy trials too. So this is just NCCN guidelines. I'm not going to go into this in detail. This is just to show you when it comes to the very early stage patients, for example, patients with T1 disease or T1, T2, you can still consider surgery first in those patients, but that's a very small patient population. The majority of the patients with local disease, we typically recommend some sort of neoadjuvant therapy. Previously, it was thought that surgery was really the key. Surgery was a way to cure these people and everything else was just kind of gravy. But if you look at some of this old data, the local recurrence rates were 34%, 46%, 23%, 31%. So these aren't great. If you're thinking I'm doing surgery and I'm going to remove the whole tumor, you would think you'd have better data to show that there was lower local recurrence rates. So let's talk a little bit about what this neoadjuvant therapy is. So I was telling you early on, a lot of neoadjuvant therapy and treatments for rectal cancer were extrapolated from colon cancer. So the standard of care for years was chemoradiation followed by surgery, followed by adjuvant chemo, chemoradiation followed by chemo, followed by surgery. But trials over the last couple of years have looked at these types of conventional therapies and compared them to total neoadjuvant therapy and have found that TNT can actually be more beneficial. So again, this is a conventional neoadjuvant therapy that we just talked about. And these are different examples of total neoadjuvant therapy. So I'm sharing a couple different examples because it's really important to note that we are still early on in these types of data being produced. And so my fellow in clinic the other day just asked me, I saw this patient in your clinic and they had this type of total neoadjuvant therapy, but now you have a patient I'm seeing today and it's a totally different total neoadjuvant regimen. What is the standard? And there really isn't a standard of TNT therapy yet because we're just starting to learn more and more about this. So the different types of TNT we talk about, there's induction chemo followed by chemoradiation, followed by surgery. There's chemoradiation or short course radiation, followed by consolidation chemo, followed by surgery. And then sometimes these patients still get adjuvant chemotherapy. So let's talk about the two big trials that really paved the way for neoadjuvant total neoadjuvant therapy as a potential standard of care. So the Rapido trial looked at 912 patients. It was an international open label randomized phase 3 trial, randomized, our favorite kind of trials. It compared conventional therapy with total neoadjuvant therapy. Patients had to have high risk features. So this is important. Patients with high risk features are at high risk for recurrence. 31% of the patients had stage T4 disease. 65% had stage N2, 27% had distal extensions 5 to 10 centimeters from the anal verge, and 33% had distal extensions more than 10 centimeters from the anal verge. So a lot of high-risk features, and these are patients, when you treat, you have a high expectation that they're going to be at high risk for recurrence. This was a schema. So I told you about the eligibility criteria. Patients were randomized to either standard of care, which they assumed was long course chemoradiation, followed by surgery, followed by optional adjuvant chemo, or the experimental arm, the total neoadjuvant arm. Short course radiation, followed by chemo, either FOLFOX or CAPOX, followed by surgery. All the patients enrolled, this is again key, had high risk stage 2 and 3 rectal cancers. The primary endpoint, they looked at disease-related treatment failure, which include local regional failure, distant METs, new primary tumor, and treatment-related deaths. And the rate of disease-related treatment failure was found to be reduced with total neoadjuvant therapy compared to conventional therapy, 23.7% versus 30%, with a p-value of 0.019 and a hazard ratio of 0.75. This is pretty exciting because, again, in the rectal cancer world, we don't get this much exciting data. They doubled the pathological CR rate in the total neoadjuvant therapy group, doubled it. We don't see these types of numbers, 28.4% versus 14.3%, and this was statistically significant. And the rate of distant METs was 20% versus 26.8%. Now, the total neoadjuvant therapy group did have a higher rate of grade 3 side effects, but again, we saw a doubling of the pathological CR rate. And you have to remember, in patients who have total neoadjuvant therapy who may not need surgery down the line, when you talk about quality of life, if you can tell a patient, I can give you chemo, radiation, cure you of your cancer, and you never need to get a stoma or have an ostomy bag, that for quality of life is huge. So the median follow-up in this trial, 5.6 years. Again, this is something that is interesting. Total neoadjuvant therapy was associated with an increased risk of local regional recurrence compared to standard of care. But again, at 5 years, the reduction of disease-free survival and distant METs were sustained, and the 5-year overall survival rates were about comparable. So Rapido really established total neoadjuvant therapy as a new standard of care option for patients with locally advanced treatment or locally advanced rectal cancer. I will say that it also showed a benefit of a more convenient short course of radiation. I mean, how many times have we heard patients complain that they don't want to be coming in for radiation for 5 weeks? So the fact that we could do a shorter course of radiation is also pretty impressive. And there was the higher rate of pathological complete response lends itself to the thought process that maybe these patients can forego surgery altogether. So basically, what this trial showed was that neoadjuvant therapy for rectal cancer is incredibly important and effective. It also showed that in a certain patient population, you can do chemoradiation and chemo and potentially not have the patients need to undergo surgery at all and not change their overall survival. So improving their quality of life by not requiring them to have an ostomy that could be permanent and improving and maintaining their overall survival benefit. So the second trial that was really transformative in the TNT space was the PRODIGE 23. And I was just talking to Dr. Nguyen about how if you listen to people at ASCO, you get the amazing Italians who call it Protégé. You hear the Americans calling it PRODIGE. So I've heard it referred to as many different ways. So I'm going to call it the PRODIGE trial today. If you've heard other things, that's why. I'm not as cool as some of the other people who present and have cooler accents than me. 461 patients with rectal cancer, and again, high-risk cancer features. The primary endpoint was disease-free survival, and the secondary endpoints were overall survival, quality of life, toxicity, pathological CR, and metastatic-free survival. So this is a schema. Patients were again randomized. Standard arm was a long course chemoradiation, followed by surgery, followed by adjuvant chemo, or chemo followed by long course chemoradiation, followed by surgery, followed by adjuvant chemo. And what this study found, again, total neoadjuvant therapy improved the 3-year disease-free survival from 76% versus 69%. It again doubled the pathologic CR, increased the 3-year metastatic-free survival rate, and there was a 98% in the total neoadjuvant group received modified FOLFIRINOX, and 92% of them completed all 6 cycles. I have to throw a caveat in here. So for any of you who treat patients or who know about FOLFIRINOX, it is not an easy treatment to get. This particular trial removed the 5-FU bolus, and it also decreased the dose from what the standard FOLFIRINOX dosing was. So the toxicities weren't as high as many of the other trials that we give FOLFIRINOX for. So that is one of the reasons why it was thought that 92% of them completed 6 cycles. That is pretty impressive. So that is something just to think about when we're talking about applying this to our patient populations. They found that the reduced duration of adjuvant chemo in the total neoadjuvant group led to less severe toxicity, including less severe peripheral neuropathy. And again, as I mentioned, the omission of some of these things led to better tolerated chemotherapy. So they did a 7-year follow-up on this trial. And they found, again, the total neoadjuvant arm achieved a disease-free survival of 67% versus 62% in standard of care. They did see an increased metastatic-free survival, which is great. Cancer-specific survival and overall survival, those all trended towards improvement in the total neoadjuvant setting. And the patients with metastatic, who had metastatic relapse, so relapse in the metastatic setting, the median overall survival was 44.4 months in the total neoadjuvant arm versus 39.4 in standard of care. So these 2 studies really led to a lot of excitement at ASCO and a lot of excitement amongst us GI oncologists, because it really transformed the way we started thinking about how we were treating these patients. So looking at the summary data that I think is important, for the Rapido trial, the 3-year metastatic-free survival rate was 80% versus 73.2%. Pathological CR, again, this is a huge point, 28.4 versus 14.3. And so a doubled rate of pathological CR when the patients did end up going to surgery. So again, both Rapido and the PRODIGE study really lend themselves to us thinking, if a patient has pathological CR, can we then move them to a watch and wait strategy instead of having them go to surgery and still cure them of their cancer? 3-year overall survival was comparable between the total neoadjuvant and the chemoradiation arms in both the studies. So the PROSPECT trial is another really big trial that has had a big impact in the total neoadjuvant setting patients. This was a randomized phase 3 non-inferiority trial looking at over 1,100 patients who were staged, clinical stage T2, T3, and all had locally advanced rectal cancer. Primary endpoint, again, disease-free survival. And the secondary endpoints, time to local recurrence, overall survival, complete resection rate, super important for if we're thinking of not doing surgery in the future in some of these patients, and a complete response rate and toxicity. So this is the schema, long course, chemo-RT, followed by surgery, followed by adjuvant chemo, versus the experimental arm had chemo first, and then they restaged the patients. After they restaged the patients, if the patient had a more than 20% response, they sent them straight to surgery. If the patient had less than 20% response at restaging, then they got chemo-RT. After that, if the patient had an R0, well, hopefully the computer does not restart. If the patient had an R0 surgical resection, then they got 6 cycles of FOLFOX. If they had R1 or R2, they got a long course chemo-RT plus more chemo. So again, remember, this is a non-inferiority trial. So of the 585 patients in the experimental group, they had radiological restaging after 6 cycles. And again, if the tumor shrank by 20% or more, then they went through that schema. In the experimental group, 53 of 585 patients needed long course chemo-RT prior to surgery. So the median follow-up in this trial was 58 months. 5-year disease-free survival rate for experimental arm was 80.8% versus 78.6%. And so they found this to be a non-inferior regimen for these patients. 5-year overall survival was 89.5% in the experimental arm versus 90.2% in the control arm. And the local recurrence rate was low and similar in both groups. So pathological CR, 22% in the experimental arm, 24% in the control. Neoadjuvant perioperative FOLFOX group did have more neuropathy in the preoperative setting. The control group had more diarrhea. And in the pre-op group, grade 3 side effects were more frequent in the experimental arm, but the control arm had a higher rate of post-op side effects, which makes sense because the majority of their therapy was being given in the post-op setting. 12 months after surgery, patients in the FOLFOX group had lower rates of fatigue, neuropathy, improved sexual function compared with the control arm. So again, looking at quality of life. So we already talked about Rapido. We talked about PRODIGE. How does Prospect fit into all of this? Well, at the 5-year mark, we're looking at 5-year here of metastatic free survival. They didn't look at that, but we're looking at the data here and it was comparable. When you look at the pathological CR, again, it had a significant pathological CR. You have to remember the Prospect trial did stratify people at multiple times during randomization. So that's why some of the data is a little bit different from Rapido and PRODIGE. But the purpose of this trial was to show that total neoadjuvant therapy is non-inferior to standard of care. And so they were able to prove that. So Rapido and PRODIGE established a new standard of care. The use of total neoadjuvant therapy is now considered standard of care for our patients. Data from the Prospect trial showed that neoadjuvant chemo alone can be very effective in treating these patients. And again, I'm emphasizing this because it's so important, and it's still, even me, who I see these patients all the time, I sometimes have to remind myself that some of these patients may not need surgery at all because they've achieved a pathological CR before they ever need to go to surgery. So you can avoid the stomas that are so uncomfortable and ostomies for patients. PRODIGE was the only trial that included adjuvant chemo regardless of their staging at the time of surgery. So we do need to think a little bit about how we stratify our patient populations. Despite the impressive rates of pathological CR, only the PRODIGE trial demonstrated an overall survival benefit, which is why we really need more trials dedicated to this type of neoadjuvant therapies. We do know that pathological CR is a poor surrogate endpoint for overall survival in rectal cancer patients. Typically, we like looking at disease-free survival, which seems to be a stronger predictor in the rectal cancer space. These are just facts that I think are important to emphasize. Chemo-RT improves survival when compared to chemo alone. We know that. Pre-op treatment, if you do end up going to surgery, allows greater conversion to sphincter-preserving surgery and improves quality of life. And pre-op treatment is associated typically with lower recurrence rates. So this is the question I get asked whenever I give talks like this. Well, that's great, Dr. Jane. How do I decide what to give to people? And it's a really hard question. We talk in 2023 about personalized care and precision oncology and really making sure that we're looking at the patient in front of us. And I think that is how you have to approach rectal cancer treatments when you look at all of these different treatment paradigms. TNT should be considered in locally advanced disease for every single patient. That is a no-brainer at this point. Anybody who comes in should be considered for total neoadjuvant therapy unless there is a contraindication like the patient is obstructed. Look at patient-specific characteristics. Most of the patients in these trials have actually had really good performance statuses. They're a little bit younger. They may not look like our typical patient population, so you really need to personalize care there. People ask me about induction chemo, short course chemo-RT, long course chemo-RT. Again, this is patient-specific. If you have a larger tumor, I would recommend starting with chemo or with chemo-RT right away. If you have a tumor that's causing major symptoms, sometimes radiation first while you're waiting for chemo approval can be really beneficial to help patients shrink those tumors, help with some of those symptoms initially. And short course radiation has been shown to be comparable to the longer course chemo-RT. If you have someone who has node-positive disease, you really need to be thinking, I want to start chemotherapy early on so that we prevent micrometastatic disease from spreading. So it really is a personalized approach, but I think in all of these approaches, we need to be thinking about chemo and radiation and combination in the preoperative setting. The other thing that I think is really important to remember is look at the patient, look at their performance status, and talk to your patient. Different patients have different abilities to do different levels of care at their own home. So you should also be thinking about that when you're thinking capecitabine versus 5-FU therapies. Prospect trial, again, I'm emphasizing this because this is a key take-home point I want you to remember. When you do total neoadjuvant therapy, there is the possibility of the patients not needing surgery. And that can also help with fertility preservation in some patients, especially in the younger patient population. We're seeing more and more young people diagnosed with colon cancer and rectal cancer. So keep this in the back of your mind as something else to consider. The challenge to adopting this non-surgical watch and wait strategy is it's very anxiety provoking for both the patient and for me as a physician. So there are really good guidelines on how you can follow these patients very closely. In the first year, every 3 months, getting imaging and getting tumor markers and digital rectal exams. The second year, some of those things move out to the chest, abdomen. The chest scans can be spaced out further, but looking at getting endoscopies regularly, continuing to get those CEAs, digital rectal exams, and pelvic MRIs. And so you space it out every year, but you need to have a really good plan in place if you're going to avoid surgery. So I'm running out of time, so I'm going to talk very briefly about MSI high and the immunotherapy part, and then I'll end with ctDNA. Only 3% of our rectal cancer patients have our MSI high, but MSI high is a positive predictor of response rates to immunotherapy agents. So NCCN has incorporated IO therapy into the guidelines now. The NICHE trial in 2022 looked at 107 patients with colon cancer and found that short course checkpoint inhibitors were very useful. There was a study that was published in the New England Journal in 2022 that every single person in the world emailed me about saying, oh my God, you can get 100% cure rate in these rectal cancer patients with immunotherapy. Everybody wanted to be on it because it was 12 out of 12 patients. They all achieved a path CR with 6 months of dostarlimab. Again, very select patient population. And then this is the data that was just presented at GI ASCO. 5 patients were treated with Nivo/Ipi. 4 patients received 1 cycle. 1 patient received 2 cycles. All 5 patients achieved a pathological CR. They were ctDNA positive at the time of diagnosis. 4 patients turned negative after therapy. None of them needed radiation. All of them agreed to a non-surgical watchful waiting approach. So in patients who have MSI high, incorporating immunotherapy in the neoadjuvant setting as a possible total neoadjuvant therapeutic is very exciting, and it makes me very proud to be a GI oncologist. Predictive biomarkers, I'm not going to go into too much detail because you're going to hear about this from other people about when it comes to precision oncology, but again, something to think about when you're looking at how you're planning out your patients' treatment plans. This is, again, I'm not going to go over this. This is something just so you have in your brain. And I think if you have access to the slides, you can look at this. This is the algorithm I share with people and how you decide which patient should go what avenue for what type of neoadjuvant therapy. And this is, again, I put this in here not to go over with you, but to have for your reference. This is just examples of some response rates to immunotherapy containing treatment regimens. And again, since I'm running out of time, I won't go into this, but talking about patients with who were MSI high, looking at their response rates to immunotherapy. And so I'm going to end with like 30 seconds on ctDNA. So we know ctDNA is great at detecting minimal residual disease. We also know that it's really helpful in finding ways to predict if patients are at high risk for recurrence. Unfortunately, the data is a bit scattered, and we need a lot more data to really utilize this in a standard of care type way. The Galaxy trial monitored ctDNA status in patients with stage 2, 3, and 4 resected colorectal cancer. They found that there was ctDNA positivity 4 weeks after surgery was the most significant prognostic factor associated with an increased risk of recurrence. So I've started using ctDNA in my practice to kind of closely monitor patients who I think are going to be at higher risk for recurrence. There was a meta-analysis looking at ctDNA in patients with rectal cancer, and they found patients who had, again, detectable ctDNA were at higher risk for disease recurrence. So I use ctDNA really in that standard, and I'm hopeful for more data coming out soon so that we can integrate it into our standard of care practices. The future of rectal cancer. There are so many cool things happening in this space right now. I'm really excited to see what the future holds. Just to see what's happened in the last 10 years with IO therapy and total neoadjuvant therapy. We are really at the cutting edge of advancing rectal cancer care and potentially impacting in a positive way the quality of life of many, many patients by avoiding surgery altogether. I did have a slide. I think it didn't make it into this final deck for some reason with our UIC trial. So if anybody's interested, we have them. And my slide that I sent, I think did not end up in here. Had lovely pictures of all the people I thank, and many of them are in this room. So if you know me, you were probably on the slide with a picture of you thanking you for all of the help you've given me in my career up until this point. So thank you so much, everyone, for listening, and I hope you learned something. And I don't think we have time for questions, but I will be around, so please feel free to find me. Oh, we do. Amazing. See, I talked so fast, we found time. So I have time. We have time for questions.
Thank you so much, Dr. Jane. I'll open up to the audience if there's any questions at this point. I know that I had one question related to the ctDNA, and especially for those patients who are choosing not to do surgery and you're watchful waiting. Do you know if any of those 3 major clinical trials incorporated ctDNA kind of dynamic changes throughout that total neoadjuvant course?
That's a great question. So a lot of the data, the ctDNA data it's very, what's the best way to put it? It's very diverse. So even the data that has been published in the ctDNA space, they didn't really look specifically at that in these trials. And it is starting to become in the rectal cancer space. We're starting to see more and more of that data come out. But again, it's very varied because all of the timelines are not the same. Some people are checking it every 3 months. Some people are checking it every 6 months. Some people are checking it with a certain type of lab. There isn't the consistency that we need to really use it in a way that we can safely say watching ctDNA will impact us in this way. The way I use it clinically, honestly, is anyone who has any sort of treatment with curative intent, and we are calling them, I don't use the word cure right away, but we say you are in what looks like a complete response. You look like you are, for now, it looks like we've going to move on to the surveillance part of our cancer treatment plan. Those patients, I order a ctDNA on all of them, and I check it every 3 months. And my patients who have a positive ctDNA at that initial visit, I tell them we are going to watch you even closer because you are at a higher risk of recurrence based on the data we have currently. Because most of the data has shown if you have a positive ctDNA after treatment with curative intent, the chance of you recurring is higher. So that's how I use it clinically. Unfortunately, we're not seeing as much consistency in the data. And I think once we have a wider breadth of data and more information on this, and we see more of it, we'll be able to be better at standardizing it. Dr. Weinberg?
That was very helpful. Sorry, that was really a helpful primer for GI cancers, which I don't see anymore, unfortunately. My question is to kind of pigeon off the ctDNA question. It has to do with clinically, what do you do with a positive ctDNA result? Are you still, you said, you know, we're going to watch you closer. What does that actually mean? Does that mean, are you going to start treatment without imaging findings? Or, because we're struggling with this in the thoracic field as well now. You guys in the GI field are way ahead of us in terms of ctDNA testing. Yeah, kudos.
Thank you.
So I just wanted to get your thoughts on that.
Yeah, it's a really good question. So it's a shared decision with the patient. So insurance won't cover imaging more often. And I don't want to start chemo on somebody who doesn't have actual evidence of disease. So the way I usually frame those conversations is I tell patients, I say, especially if their CEA is negative and their imaging is negative, but their ctDNA is positive. What I tell them is we have 3 different data points here. The ones that we've used for years and years and years are showing you don't have cancer. But the one that shows there's microscopic cancer cells is showing that there's something microscopic floating around somewhere in your body, but we cannot see it. So what I do for these patients, I still maintain the same every 3-month imaging. And sometimes NCCN says 3 to 6 months. I never go to 6 months in those patients until we're more than 2 years out. And I will do 3 months imaging. Their CEA, normally those patients are getting CEAs once every 3 months. Depending on how high the ctDNA is, I sometimes have them come in for CEAs every month, especially if they had a high CEA preoperatively. Because if their CEA is negative and it was positive preoperatively, then I can be a little bit more assured that if I see their CEA staying negative, staying 0, then I'm less concerned that the cancer is coming back. If the CEA starts climbing, then I start searching. Then I plan for, if I need to plan for a repeat colonoscopy or flex sig, then I say we need to do imaging now. Instead of in 3 months, let's do it in 2 months. And then I have a data point where I can fight with the insurance companies and say, hey, standard of care is this, but my patient's ctDNA is showing positive and now their CEA is climbing. So that's how I do a more aggressive kind of watch and wait approach. And in the very few patients who I've done all of this and they haven't gone to surgery because I'm assuming they're cured with just total neoadjuvant therapy, I do the exact same thing. And so that watchful waiting is also very, very specific and targeted for those 3 data points. And I've seen patients who their ctDNA will be positive, and I've seen their CEA starts climbing, and then 2 months later, their imaging comes back positive. Dr. Gotti?
Hey, I've got the opposite question, which is for patients who have ctDNA clearance, why on earth are we still imaging them and doing all this other stuff?
That is a great question. So 1, because it makes patients feel better. And 2, I have seen cases where you diagnose secondary malignancies, right? Patients who've gotten chemotherapy are at risk for secondary malignancies, not as much in our population because of the chemo we give, but that type of surveillance can be very helpful in a variety of ways. Why we're doing it? I'm doing it because it makes me feel better because I don't still 100% trust ctDNA. I have heard anecdotal cases of people having a negative ctDNA and then having positive imaging and having a recurrence. So until I see real data that I can trust that the ctDNA is going to be predictive of a recurrence, I will continue doing the things that I feel comfortable with. If a trial comes out, which maybe we do it at UIC, a trial comes out that definitively says ctDNA negativity will confirm that there is no active cancer and that chance of recurrence is very, very low, almost 0, then I think I would stop scanning. But I don't think I have the confidence in ctDNA just yet. Someday, maybe by the time I retire.
Yeah, and I'll make just a personal point here. I think it's with ctDNA and all these tests that are coming out where we don't quite know how is this going to impact therapy. It also causes us a lot of anxiety. It causes patients a lot of anxiety. The personal story I'll share is my dad had stage 3 colorectal cancer last year, got surgery. His 4-week ctDNA was negative. So when this Galaxy trial came out, he was ecstatic for me to share that with him, like exactly the time it came out. But you can only imagine if that was positive, he obsesses over everything. He had a 2-millimeter nodule in his lung, and I'd tell him, don't worry about that. I see those all the time. But if that would have come back positive, the amount of mental anxiety that would have caused him or patients is very high. So when we don't know quite what to do with these tests, I think it puts all of us, patients and oncologists, in a tough position.
Totally, and that's why it's shared decision making. And I talk to all my patients about CTD, and I tell them, this is what we know, this is what we don't know. If it comes back positive, don't panic, because it doesn't mean your cancer is back. It means that there is a risk that your cancer is going to come back. So we are going to make sure that we monitor you very closely to prevent that from happening.
Any other questions? Okay. Thank you so much, Dr. Jane.
Thank you.
At this point, I believe we are up for a break. I know at 3:35, we do have a product theater that's in, I believe, this room right here, put on by our sponsors at Regeneron. And then otherwise, after that, we'll come back here at 4:35, and we'll pick up with Dr. Weinberg's lecture, and then we'll finish with mine after that. Thank you.